Mustafa, it's so good to see you here at the 65th annual ASH meeting in San Diego. You're presenting some interesting stuff, but before we go into this, tell us a little bit about where you are and what you're doing right now.
Great. Thank you so much for this opportunity. My name is Mustafa Wasifuddin. I'm a second-year internal medicine at Brookdale Hospital, and I'm interested in pursuing a fellowship in hematology oncology. So I am interested in the advances that the field is making, very, very breakthrough advances and at a breakneck speed. So a lot of the research has gotten me interested, and I thought ASH would be the best way to exhibit my research.
Well, you're in the right place, right here. So fellowship is guaranteed. Look, so you presented something about racial disparities in one of the most common lymphomas out there, non-Hodgkin lymphomas. Tell our viewers and listeners, first of all, what made you decide to do this kind of research, and how did you do it? Where did you get the data from?
Great. So, diffuse large B-cell lymphoma or non-Hodgkin lymphomas in general are an area of my interest. I'm interested in malignant hematology. So, I noticed that there isn't not much data on diffuse large B-cell lymphoma in adolescents and young adults. Traditionally, this age group, which is the age group between 15 to 39 years of age, has had worse outcomes compared to children and adults when it comes to malignant hematology. There wasn't much data, so I decided to explore, combine my interests with a dearth of literature, and I looked at the SEER database, which is the Surveillance and Epidemiological Research database. It covers about 27.5% of the US patient cancer population. And I tried to look at disparities in incidence and survival outcomes between different races.
So they do report, in SEER, they report races and ethnicities?
Absolutely, absolutely. So incidence in SEER can be found in terms of annual percentage change, which is what we expressed as our incidence data. And survival in SEER can be obtained by calculating the overall survival, as well as cancer-specific survival, which were the two survival outcomes we studied in our research.
So you got this information and you're looking at survival. What did you find out in DLBCL in terms of survival between race and ethnicities as well? You're looking at the age brackets as well as race and ethnicity?
And the incidence,
okay.
absolutely.
So what did we find out?
So the interesting thing I found out is that the incidence of DLBCL has gone down by negative 0.5% APC over the last 20 years. We looked at data over the last 20 years. We found about 8,500 patients, and over there we saw that in this age group the incidence has gone down.
Age group?
Between 15 to 39.
15 to 39.
Yeah, exactly, the AYA group. Interestingly, I noticed that the incidence didn't go down equally amongst all ethnicities. The black patient population showed the highest decrease in incidence in the AYA group in DLBCL. The white population actually showed the lowest decrease in incidence of DLBCL. An interesting finding was that the only ethnicity out of all the racial groups to show an increase in incidence was Asian and Pacific Islander group, which was about 1.88%. The only race to show an increase in incidence. So I was very curious why this happened, and I looked at studies across China, Japan, South Korea with a similar racial makeup, and they all had an increasing incidence of DLBCL, and they could not explain why, exactly why this happened. So I looked back and I saw that there are certain risk factors such as Epstein-Barr virus, which is a risk factor for DLBCL. It is in higher prevalence amongst this patient population. So the other studies had not reported that before, and I'm hoping to include this in my final manuscript and report that this could potentially be a factor as to why we have an increasing incidence of DLBCL among specifically this age group.
But there could be other reasons, no? I mean, it's very difficult. Yep. I mean, my sense is it's very difficult to assume it's just really EBV, right?
Absolutely. So EBV-associated DLBCL is not the most...
It's a very small, tiny...
It's a very small percentage. However, there aren't any... So that's one of the points of my research, is to get more people into thinking as to what exactly it could cause.
Have you thought of environmental factors?
Absolutely, environmental
occupational
factors.
exposures.
These are all things to think about. I'm trying to look at studies that explore these factors more in detail. I haven't been able to come across any studies so far in the literature. Maybe I could talk to more researchers at these institutions and get in touch with them and, find out what their thoughts are on these on environmental risk factors or racial or genetic risk
The other
factors
thing,
or
I
anything.
wonder if some of the incidence is because the diagnosis, there's some element of it that you make a diagnosis in a specific race, ethnicity, or age group early on simply by the fact that this demographic might seek medical attention sooner. There may be other elements outside of the biology of disease. So, I mean, I like what you're doing, and I think it would be very nice to try to separate how much of your observations are biology of the disease versus other factors that might be really leading to these observations.
Absolutely, and that's one of the limitations of SEER. It's hard to follow, hard to gauge which ethnicity seeks care earlier and which doesn't, or the temporality of these things is very hard to gauge just from SEER, which is one of the limitations of my study.
Look, congratulations on the great work. I look forward to reading the manuscript and more research from you. Good luck.
Absolutely. Thank you so much.
Thank you so much.
I appreciate it.